Hello. Today, we are going to talk about headaches. Because headaches can be located around the eyes and because they can be related to vision, optometrists frequently are asked to evaluate patients with headaches. There's always a worry about missing a serious cause of a headache, including a brain tumor or an aneurysm. And it's critical that we identify the red flags associated with the more serious headaches and that we're able to differentiate these from a benign headache. Today, we are going to go over the various characteristics of primary and secondary headache types so that we know the symptoms and signs that will help us come up with a correct diagnosis. Particularly, there are two main aspects that I see as critical for our profession in dealing with headaches. First, we want to make sure that we pick up any vision related headaches. We want to make sure that the headache isn't easily corrected with glasses or vision therapy. Second, we want to recognize and deal with any headache that is potentially vision threatening or life threatening. 90% of headaches are primary headaches, meaning that the headache has no known underlying cause. The three main types of primary headaches are tension headaches, migraine headaches, and trigeminal cephalgias, of which the most common type is a cluster headache. Primary headaches do not need any additional workup, such as neuroimaging. Secondary headaches are not nearly as common, but they have the potential to be very serious. They may have an underlying cause such as a mass, a hemorrhage, or an aneurysm, and they do need additional workup. Whenever you have a new onset headache, you always want to rule out a secondary headache. There are a number of causes of secondary headaches that we'll discuss today, but the most common cause of death associated with a secondary headache is due to vascular events, such as a subarachnoid hemorrhage following an aneurysm rupture or an internal carotid artery dissection, both of which can have ophthalmic signs. Even though they aren't as emergent, we want to be very familiar with primary headache characteristics so that we'll be able to differentiate a more common type of headache from an emergent situation. By far, the most common headache is a tension headache. Up to 80% of the population have experienced this type of headache. This is a recurrent, dull, bilateral headache that's mild to moderate in intensity. It's described as having a hat band distribution, having a pressure or tightening quality in the area around the forehead. The headache lasts anywhere from 30 minutes to 7 days. And the lack of associated symptoms helps us to differentiate this type of headache from a migraine headache. There's no nausea or vomiting associated with a tension headache, and the headache is not aggravated by physical activity. Photophobia or phonophobia may be present, but not both. This is the headache that I find most difficult to differentiate from a vision-related headache. Vision headaches are often in the same area, they're bilateral, and they can occur at the end of the day, the same as a stress or tension headache. A migraine is a chronic unilateral headache that comes on gradually. It is commonly on the upper half of the head, but it can involve any part of the head. The headache lasts between 4 to 72 hours when left untreated, And to make the diagnosis, there must be at least two of four qualities. It must be unilateral, pulsating, moderate to severe in intensity, or aggravated by physical activity. In addition, the headache must be accompanied by either nausea and vomiting or photophobia or phonophobia. Trigeminal autonomic cephalgias, such as a cluster headache, are always unilateral, often within or around the orbit. The pain is explosive in quality and very severe. It generally lasts from 15 minutes to 3 hours and can occur 1 to 8 times per day. Most episodes occur in clusters, hence the name, lasting 2 weeks to 3 months, followed by a period of remission of between 6 to 24 months. There will be at least one autonomic symptom on the same side as the pain. So they may have anisocoria, orthosis, or lacrimation. These patients might also get restless or agitated. During an attack, the person will pace the floor or even become violent, striking their head or fists on the wall. Tension headaches are generally alleviated with over-the-counter analgesics. Ibuprofen has been found to be more effective than acetaminophen. Muscle relaxants, as well as relaxation techniques or physical therapy, may be helpful in preventing tension headaches. Acute migraine treatment generally starts with a simple analgesic medication such as acetaminophen or a non-steroidal anti-inflammatory medication. If this isn't successful, then triptans can be given orally, nasally, or subcutaneously. Prevention of migraines may be necessary if the headache interferes with a daily routine, if the patient has more than one headache per week, or if the acute medications are ineffective or contraindicated. Preventative medications include tricyclic antidepressants, anti-epileptic medications, or beta blockers. There are a number of alternative therapies for treating migraines. The most promising seems to be with oral magnesium, which results in decreased migraine frequency and intensity in multiple studies. Botox injections have been shown to be effective in headache prevention if chronic migraines are present, meaning that the patient has 15 or more headache days per month. Botox injection involves 31 injections in the face, head, and neck regions. But the nice thing is that there are no systemic adverse reactions. Triptans are helpful for cluster headaches as well. Subcutaneous sumatriptan is the most effective since subcutaneous forms act within 15 minutes. Remember that these are very short but extreme headaches, so you want to get the medication into the system as quickly as possible. Triptans with nasal spray administration are effective in 30 minutes. Oral administration is generally avoided since the effect is delayed significantly. In about 2/3 of patients with cluster headaches, inhalation of 100% oxygen aborts the headache completely after 15 to 20 minutes. And this treatment is nice because there are no side effects, and the treatment can be repeated quite often. Preventative medications are maybe necessary also for cluster headaches. Verapamil, lithium, and topiramate are the most effective at preventing cluster headaches. Now, the most common cause of a secondary headache is medication overuse headache. Now, this isn't a life-threatening secondary headache, but I do want to mention it here because number one, it's very common. And number two, it's related to the primary headache disorders. Medication overuse headache develops in patients with pre-existing chronic migraines or tension headaches when they overuse pain medications. If you don't already have a history of headaches, you don't get medication overuse headaches just by taking these medications chronically for a different condition. Half of patients with chronic headaches, again, meaning that the headaches are occurring more than 15 days per month, have medication overuse headache. It's reported in 19% of tension headaches and 31% of migraine sufferers. The amount of medication needed to produce medication overuse headache is dependent on the type of medication used. Use of triptans more than 10 days per month or NSAIDs more than 14 days per month can cause medication overuse headache. Opioids can cause medication overuse headache if used more than 8 days per month. And barbiturates only need to be used more than 5 days per month. In general, you want to limit treatment to 2 days per week or less than 10 to 15 days per month to prevent medication overuse headache. Treatment of medication overuse headache involves limiting the medication use. There is a latency period prior to resolution of the symptoms, but 50 to 70% of patients have improvement of the headaches after discontinuing the medication. In addition, preventative medications work better after discontinuing the overused medication. One study looked at 60 patients with chronic migraines, and after detox, none had chronic migraines after 2 months following a 2-week detox. The most important concept here is that we educate our patients that this can occur. So let's switch gears now and talk about potentially life-threatening causes of secondary headaches. As you can see, there are a number of causes of secondary headaches, and we'll go through characteristics of each of these. Luckily, many of the causes can be ruled out with a few simple questions, which we will also cover. Subarachnoid hemorrhage is one of the most feared causes of headaches. An aneurysm bursts, and we have a hemorrhage in our brain. These patients have what's described as a thunderclap headache, a very severe headache that reaches its peak within 60 seconds. The headache is worsened by physical exertion, such as Valsalva maneuver, exercise, or intercourse. And other neurologic symptoms are generally present, such as nausea, vomiting, stiff neck, seizures, or altered consciousness. If this is suspected, the patient should be sent emergently to the emergency room. There, they'll likely have a CT scan, and if the CT is negative, they'll undergo a lumbar puncture looking for blood in the cerebral spinal fluid. But ultimately, these patients should be out of our chair and into the emergency room within minutes. This is a patient that we saw with an aneurysm, and she was experiencing headaches. She was in her 30s and referred to us the same day because she was having the worst headache of her life. And she was a migraine sufferer, so she knew what a bad headache was, but this was much worse. She was unable to move her eyes at the time, but it was unclear if this was due to restriction or just pain. We sent her to the ER and we gave the ER a heads up that she was coming and what we suspected. And they had her in neurosurgery that same day. Subdural hemorrhages can occur even with mild trauma, such as coughing. Also consider this if the patient's taking anticoagulant medications or antiplatelet medications. It's most common in older patients. And if it's suspected, do look for signs of abuse in these patients, as they may not volunteer this information. This headache is a dull headache that's worse at night. They'll generally have other neurologic symptoms. And a subdural hemorrhage can be particularly dangerous because the signs and symptoms may not appear until 2 weeks after the trauma. These patients should have a CT, again, looking for blood around the brain. Hypertensive encephalopathy usually occurs with blood pressure that is higher than 200 over 130. These headaches are worse in the morning and improve through the day. These images show a patient that we saw with headaches and bilateral disc edema secondary to hypertension. The patient's blood pressure was 260 over 140 when she was originally seen. Headaches in pregnancy and even up to 6 weeks postpartum can indicate preeclampsia. The highest risk is actually the first week post-delivery. This diagnosis is made by high blood pressure on 2 occasions, as well as other symptoms and signs. Here, the obstetrician should be consulted immediately. If symptoms are severe, urgent delivery of the baby may be necessary. Meningitis can be bacterial, viral, fungal, parasitic, or even have a non-infectious cause. The classic triad includes headache, fever, and neck stiffness. Be particularly suspicious of this if the patient is immunocompromised, keeping in mind that diabetic patients are immunocompromised. Consider carbon monoxide poisoning if there are multiple people from the same household with the same symptoms. This is most commonly due to smoke inhalation, but faulty furnaces or exposure to engine exhaust can also cause these dangerous headaches. In mild cases, there will be flu-like symptoms such as nausea, dizziness, and muscle pain. In severe cases, there's syncope, neurologic deficits, or even death. Internal carotid artery dissection is a common cause of stroke in children and young adults. Generally, there is some link to cervical trauma, but it may be relatively minor trauma, such as sneezing, chiropractic manipulation, rotation of the head or neck, yoga, or prolonged head tilt, like when you're talking on the phone. Connective tissue abnormalities may or may not be present. Headaches is one of the main symptoms occurring in 70% of these patients. They may also report neck, ear, or jaw pain. Remember that the sympathetic fibers surround the internal carotid artery. So the head and neck pain associated with internal carotid artery dissection is often accompanied by a Horner syndrome. If you have a Horner syndrome associated with a headache, it should be considered an internal carotid artery dissection until proven otherwise. This may be mistaken for a cluster headache, since there are autonomic symptoms with head pain. But this condition has very serious consequences if the diagnosis is missed. The patient may have permanent vision loss due to retinal ischemia, but the dissection also puts them at a very high risk of stroke. An MRI will show a hematoma in the blood vessel. These patients should be admitted to the hospital, and IV anticoagulation or antiplatelet therapy is needed for treatment. If the diagnosis is made promptly, serious complications can be prevented. This is actually a patient that was originally seen in the ER and told nothing was wrong. He did have a left Horner syndrome as well as pain. And you can see that here's the normal right internal carotid artery, and you can see the hematoma within the left internal carotid artery, indicating a left internal carotid artery dissection. Giant cell arteritis or temporal arteritis is an inflammation of the medium and large vessels. Headaches is the most commonly reported symptom of patients with giant cell arteritis. It's the presenting symptom in 35% of biopsy-confirmed giant cell arteritis. The headache can be either unilateral or bilateral, and it generally has non-specific characteristics. So giant cell arteritis should be suspected in all new onset headache patients that are over the age of 50. Look for a tender, thickened temporal artery with a decreased pulse. Visual symptoms that are associated with giant cell arteritis include amaurosis fugax, permanent vision loss, or double vision. Other findings that may help make this diagnosis include jaw claudication, as well as scalp tenderness or necrosis along the artery. Systemic symptoms of polymyalgia rheumatica may also be present, including fever, malaise, weight loss, or muscle pain. But do keep in mind that 20% of patients that lose vision due to giant cell arteritis have no systemic symptoms. Recognizing giant cell arteritis early can prevent vision loss, as well as stroke and myocardial infarction. An ESR, C-reactive protein, and a CBC with platelets should be ordered immediately, but the test that ultimately confirms the diagnosis is a temporal artery biopsy. These patients, again, should be sent to the ER, and steroid treatment should be initiated immediately. The headache and systemic symptoms generally improve quickly with steroid treatment, but unfortunately, vision loss is usually irreversible despite steroid treatment. The headache associated with angle closure glaucoma is typically a frontal unilateral headache lasting less than 4 hours. And this type of headache can be easily mistaken for a migraine. Angle closure is more common in older patients, in hyperopes, and those of Asian ethnicity. The headache is triggered by low lighting conditions that cause pupil dilation. In addition to ocular pain, patients will have nausea and vomiting and visual symptoms similar to what you would expect with a migraine. The blur is usually accompanied by the patient seeing halos around lights, which is caused by corneal edema. Ultimately, the diagnosis and treatment of angle closure is through intraocular pressure. Reducing Intraocular pressure needs to be done emergently with anti-glaucoma drops, such as beta blockers, alpha adrenergic agonists, and pilocarpine, as well as an oral carbonic anhydrase inhibitor. Laser peripheral iridotomy is the definitive treatment. These images are from a 35-year-old white hyperopic female. You can see that she has very narrow angles with von Herrick as well as with gonioscopy. She did have a past diagnosis of migraines where the headaches were on one side of the head, mainly around the eye, as well as nausea. Never assume previous physicians have made the correct headache diagnosis. Make sure that you feel comfortable that the signs and symptoms line up with the diagnosis. Pituitary apoplexy is acute ischemia or hemorrhage of a pituitary gland that occurs with pituitary adenomas. However, you can't rely on the fact that the patient knows that they have a pituitary tumor to rule this out. Pituitary tumors are often asymptomatic, so the patient may not be aware that they have a tumor until after the apoplexy event. This is more common in pregnancy because there is a 139% increase in the size of the pituitary gland during pregnancy. The headache is severe and sudden, similar to what you would get with a subarachnoid hemorrhage. Ophthalmoplegia occurs in 70% of patients. So patients with a sudden headache associated with inability to move the eyes or vision symptoms should be sent immediately to the ER for neuroimaging. This condition can result in death very quickly due to the lack of pituitary hormones being released. In the ER, they will receive systemic glucocorticoids that are necessary for survival. Now we have headaches that are caused by increased intracranial pressure. This may be idiopathic, it may be due to a tumor, or it may be due to a clot of one of the veins draining the brain. Idiopathic intracranial hypertension is caused by increased intracranial pressure with no evident cause. There's no space-occupying lesion, and cerebrospinal fluid analysis is normal other than a high opening pressure. It's most commonly in young, obese women. The headaches can be severe, and they're generally not localized to any one particular area of the head. Associated symptoms include monocular or binocular transient vision loss, as well as pulsatile tinnitus. And treatment involves weight loss and acetazolamide. Optic nerve fenestration or a ventricular shunt is necessary if vision loss progresses despite oral treatment. A tumor in the head can cause a progressively worsening headache that's worse in the morning or when the patient is in a head down position. Now, it would be unusual that a brain tumor would present with just an isolated headache. Generally, these patients will have other symptoms such as nausea, vomiting, seizures, or other neurologic or neuropsychiatric disorders. But they may not mention these symptoms to you. If there is a history of cancer, neuroimaging should always be obtained in those with a new onset headache. Treatment involves caring for the underlying cause, and generally a neurosurgical consultation is necessary. Thrombosis or a clot of a cerebral vein can cause stroke at any age, but the average age is 39 years. Here, there is a headache associated with increased intracranial pressure and papilledema. A headache occurs in 90% of patients with cerebrovenous sinus thrombosis. It often is gradual onset, but may be sudden and severe. There is a higher risk of venous thrombosis in those taking oral contraceptives, and it's more likely to occur during pregnancy or the postpartum time period. Also be suspicious if they have a clotting disorder. Treatment involves anticoagulants. A thrombectomy or removal of the clot may be necessary if the symptoms progress despite anticoagulant therapy. These are images from a thin 19-year-old male experiencing severe headaches. He'd been to the ER twice and told that there was nothing serious wrong. As you can see, he does have bilateral disc edema. His MRI was reported to be normal, and his opening pressure was 28 centimeters of water. Despite the normal MRI appearance, he didn't fit the typical characteristics of idiopathic intracranial hypertension. He was male and he was thin. So we needed to find a reason for the increased intracranial pressure. Due to lack of insurance, he refused to do an MRV, but when I went back to closely look at the MRI myself, you can see that there is blockage of the left jugular vein. You can compare that to the open right jugular vein. So those are our most worrisome headaches. Now that we're familiar with the various causes of headaches, we want to have a plan to reliably identify and differentiate the headache types. There are quite a few conditions that can cause secondary headaches, but many of the causes can be ruled out with a few simple questions. I do want to point out that you cannot use the fact that a headache gets better with an analgesic to differentiate between primary and secondary headaches. Many serious headaches causes, including subarachnoid hemorrhage and internal carotid artery dissection, have been reported to improve with NSAIDs or anti-migraine medications. A detailed history is the most critical aspect of headache examination. Demographics can help eliminate a number of causes quickly. If it's a young obese patient, think idiopathic intracranial hypertension. In an elderly patient, think giant cell arteritis or possibly a subdural hemorrhage. Medical history can point to certain causes. Recent pregnancy may indicate preeclampsia or cerebral venous thrombosis. If there is a history of cancer, suspect a space-occupying lesion. And if the patient is immunocompromised, think about meningitis. Look at the onset of the headaches. Is there a gradual onset or a sudden onset? If there's severe, sudden symptoms, then emergent causes must be ruled out. A thunderclap headache that starts suddenly and severely indicates a vascular cause. The most critical diagnosis associated with a sudden severe headache is a subarachnoid hemorrhage, but other causes, including an internal carotid artery dissection, cerebrovenous sinus thrombosis, or angle closure, can cause this type of severe sudden headache. Also, in terms of the onset, ask what they were doing when the headache started. A headache brought on by exertion, sexual intercourse, or Valsalva maneuver is indicative of a subarachnoid hemorrhage. Ask about prior headaches. If the headache is similar to past headaches, except of a longer duration, or it's becoming more severe, or has become resistant to traditional treatment, this is more likely to be a primary headache. And these patients don't need additional imaging. Asking about associated symptoms is critical. Do they have a fever? If so, you might consider meningitis. If they have flu-like symptoms but no fever, think about carbon monoxide poisoning. Do they have unilateral weakness or sensory loss? Think about a space-occupying lesion. If they have eye pain, think giant cell arteritis or angle closure glaucoma. If vision changes are present, think again about giant cell arteritis, angle closure glaucoma, or something that's causing increased intracranial pressure, like idiopathic intracranial hypertension, cerebral venous sinus thrombosis, or a mass. Pituitary apoplexy should be considered if there are extraocular muscle restrictions associated with a headache. Also, think of an impending subarachnoid hemorrhage due to a posterior communicating artery aneurysm if the patient has a cranial nerve 3 palsy. A cranial nerve 6 palsy may indicate increased intracranial pressure. If disc swelling is bilateral, this is suspicious for papilledema. However, remember that you may have other causes of disc edema associated with a headache. Specifically, if there's unilateral swelling in an older patient, consider giant cell arteritis or arteritic ischemic optic neuropathy. The location of pain can also guide us to the cause. Unilateral temporal or facial pain can indicate giant cell arteritis. Keeping in mind that trigeminal neuralgias or sinusitis can also cause unilateral facial pain. Unilateral neck pain may be indicative of internal carotid artery dissection or a vertebral artery dissection if the pain is in the back of the neck. If they have unilateral eye pain, consider angle closure. Cluster headaches or optic neuritis can also cause unilateral eye pain. Now, you can remember the headache red flags by thinking about the acronym SNOOP4. It stands for systemic signs, neurologic signs, sudden onset, onset after the age of 50, and a change of pattern of the headache. The P has 4 subcategories, which is where the 4 comes in. Progressive refers to a change into a daily continuous headache. A worsening of the headache with Valsalva maneuver, such as bearing down or lifting heavy objects, is always worrisome. And positional aggravation refers to a headache that's worsened when going from a lying position to standing up or vice versa. And of course, if papilledema is present, this is always a red flag for an emergent cause. Now, they have found that the most helpful of these red flags in order of helpfulness are 1, the sudden onset. Number 2 is associated neurologic signs and symptoms. And number 3 is the onset of new headache after the age of 50 years. So any of those three are a huge red flag. Some red flags can lead to specific diagnoses. Systemic signs such as unexplained fever, chills, or weight loss are indicative of meningitis or giant cell arteritis. If they have the systemic sign of being pregnant, consider preeclampsia, cerebrovenous sinus thrombosis, or pituitary apoplexy. Neurologic signs, including weakness, sensory loss, double vision, or ataxia, are indicative of a space-occupying lesion or a vascular disorder, including a subarachnoid hemorrhage or a subdural hemorrhage. Look for signs of a Horner's syndrome as well. Headaches that reach peak intensity within 1 minute, such as a thunderclap headache, is indicative of a subarachnoid hemorrhage. However, not all thunderclap headaches are related to a subarachnoid hemorrhage. When thinking about sudden onset headaches, also consider a carotid artery dissection, cerebrovenous thrombosis, angle closure, or pituitary apoplexy. Serious headaches are 2 to 3 times more likely in patients over the age of 50. A new onset headache in a patient over age 50 is a concern for neoplasm or malignancy, for occult trauma causing a subdural hemorrhage, for giant cell arteritis, or an infection. A change in pattern or a progressive headache can be a sign of a serious underlying cause. If an existing headache evolves into a daily headache, consider malignancy or perhaps an inflammatory disease or vascular disorders. A headache that's worsened with Valsalva maneuver or activities like sneezing, coughing, or exercise is indicative of a subarachnoid hemorrhage, tumor, or hydrocephalus. Intracranial hyper or hypotension can cause headaches that are worsened by postural changes. Keep in mind that neck issues can cause this as well. Papilledema is indicative of malignant or inflammatory disorders, intracranial hypertension, or cerebrovenous sinus thrombosis. Anytime a patient has a headache associated with visual changes, one must consider secondary causes. Now, a typical aura is not a serious concern, but make sure that the aura characteristics fit the typical pattern of a scintillating colors or a scotoma that develops over 5 to 20 minutes and resolves within 60 minutes. If there is monocular vision loss with a headache, consider a transient ischemic attack, optic neuritis, giant cell arteritis, or angle closure glaucoma. Headaches associated with transient binocular vision loss occurs with idiopathic intracranial hypertension, cerebrovenous sinus thrombosis, or an intracranial mass. Homonymous hemianopia is a concern for a brain tumor, cerebral infarction, or intracranial hemorrhage. And anytime papilledema is present, an emergent workup should be done looking for causes of increased intracranial pressure. Now, we've been talking a lot about serious causes of headaches, but we also need to consider ocular problems when a patient comes in describing pain in or around their eyes. It's important to look at refractive and binocular vision issues causing asthenopia. Ask about the amount of time they spend on the computer, look for uncorrected refractive error, as well as convergence and accommodative issues. This type of pain is generally frontal or peribulbar, and patients may also describe eye fatigue or blurry vision. A careful visual examination, including the possibility of a psychoplegic examination, is necessary. And treatment, of course, involves proper refractive correction, vision therapy, and visual rest. Corneal epithelial disease, such as an abrasion or infection, corneal foreign body, dry eye, or contact lens irritation can cause eye pain. This is usually anterior pain, but it can be referred to the retrobulbar region. Symptoms vary from ocular discomfort to very sharp pain or foreign body sensation. Often, there are other signs that help make the diagnosis, such as tearing, photophobia, or hyperemia. Episcleritis, scleritis, or uveitis can cause intense pain. Optic neuritis will cause pain with eye movements. A trochlear headache or trochleitis is an inflammation of the superior oblique tendon within the trochlea. These patients will have pain right below the medial brow, and it may worsen with down gaze in adduction. It's a continuous dull ache of moderate to severe intensity. Palpation will cause exquisite tenderness, and there may be swelling. A trochlear headache is generally idiopathic, but it may be secondary to systemic inflammatory disease such as rheumatoid arthritis, lupus, or sarcoidosis. It's actually unresponsive to migraine treatment. Rather, a single corticosteroid injection into the trochlear area provides rapid relief. Inflammation of an extraocular muscle, such as idiopathic orbital pseudotumor, will cause pain with eye movements as well as double vision. And Tolasa-Hunt is an idiopathic granulomatous inflammation within the cavernous sinus, and it will also cause painful ophthalmoplegia. An MRI will show a lesion within the cavernous sinus in this case, and corticosteroids will produce rapid improvement of the pain. I hope you now feel more comfortable with these headache patients. Unfortunately, there are still a lot of people with headaches that no one can find a cause. There are whole clinics specifically dedicated to treating the pain of these patients. But again, as an optometrist, we want to make sure that the headaches are not associated with an easily treatable vision cause. And then second, make sure that there are no signs that could potentially cause serious implications for your patient. Beyond that, it is nice to work with a good neurologist that can aid in symptomatic treatment. Thank you.